Supplemental Anatomy Review, Session 3, Lower Limb Musculature. Like I told you guys in the email that I sent you, these videos are going to be much shorter for the rest of the time because I know you all have a lot to study for, a lot of quizzes and things like that. So my goal is to keep them all under 10 minutes so that you're not stressed out, right? Okay. All right, so let's start going. We're going to look at muscles of the lower limb, pretty much. Anything that attaches slightly proximal to the knee, or anything pretty much that would be contained in an AFO. So when we look at our dorsiflexors, you guys already should know all of these. These are in the anterior portion of the foot, and they are going to extend at least past the ankle, right? Because we have to have dorsiflexion. So our most common is our tibialis anterior. It's the strongest out of all these. And most of the time we are worried about injuries to the tibialis anterior. So specifically, one of the most common injuries we have that affects our anterior group is an injury to the deep peroneal nerve, which is going to run right in the neck of the fibula. So whenever we make our trim lines for an AFO, we know that we want to be distal to this peroneal nerve so that we don't cause impingement and cause foot drop. Additionally, besides the peroneal nerve palsy or having something go wrong with this nerve, we will see drop foot often in patients that have experienced a stroke. So a lot of times this limb will be very flail. Okay, so whenever we do have a flail limb, we'll have something in an AFO called a dorsi-assist, and its name implies exactly what it does. It assists in dorsiflexion if we were to have a flail foot that looks like this. So when we look at our plantar flexors, again, our gastroc soleus or triceps surae is going to be the strongest group, and then we have the other ones here that also help to stabilize the foot and ankle and provide plantar flexion. So a common injury that we see, though, is with the posterior tibial tendon. We know that this tendon inserts on the navicular right here, and so frequently if we see a collapsed arch, it can either be due to the structure of the actual arch itself and problems within the bones, or frequently it's because of this posterior tibial tendon inserting on the navicular. This tendon either is damaged or the muscle itself is very weak or is atrophying for some reason and causing this arch to collapse. So a lot of times that's when we talk about having a UCBL that's able to come in here and control the hindfoot. We're also able to support this navicular because frequently we see posterior tibial tendon dysfunction in individuals that are overweight or pregnant because they're bearing a lot of load through this arch and it's causing this tendon to be very stretched, or patients who might play a high impact sport such as basketball that causes a lot of landing and a lot of vertical forces to come through this arch and then cause it to be flattened out. So this is a terrible color to choose. Wow. Okay, so all the weight transmitting through the foot causes the arch of the foot to slowly become less and less and less because this tendon right here, this is so bad. Okay, so that tendon right there is just being stretched as the navicular is being driven into the ground by all the weight that is compressing. All right. So now let's go ahead and go away, pen. Alright, let's look at the inverters of the foot. Our two main inverters come from the anterior and posterior tib muscle, and they're going to insert on the medial aspect of our foot. Then for our everters, we're going to have our fibularis, longus brevis, and then our tertius, the third one on the backside, helps with everting a little bit, but we know that these are going to insert on the lateral part of the foot, either in the cuneiforms and the fifth metatarsal like the fibularis longus does, or in just the fifth metatarsal like our fibularis brevis. Okay, so keep in mind that our fibularis longus and brevis are running through this peroneal groove. Remember, these are also known as fibularis longus and brevis. So they're running through this groove on the calcaneus where we do have contact with our UCBL, where we do this little dig in. Now, digging in enough could impair these tendons, but the likelihood is not very high because you have such a cushioned heel and plantar surface of your foot. The likelihood of crushing these tendons isn't very high, but again, just keep those in mind. Right, and then an injury to the inverters or everters would cause a rear foot or a hind foot valgus serratus, just depending on with the situation. So oftentimes we see that a lot of our inverters aren't very strong, or we have a problem with that. So for example, if our tibialis anterior is injured by the peroneal nerve being injured, then we'll see the medial longitudinal arch collapse and see ankle valgus occurring because the tibialis anterior isn't able to help the tibialis posterior support the medial side of the foot and hold that arch intact. So either one can be seen with rear foot valgus or varus, but most commonly we see a rear foot valgus occurring. Alright, so that is pretty much it for this week. And let's see. Yeah, that's about it. Okay, let me know if you guys have any questions.